Greeting from Hong Kong. This is David Siu from the University of Hong Kong. Thank you for inviting me to give a talk in this very important webinar. Today, I'm going to share with you some of our experience in managing pulmonary hypertension in connective tissue disease, focusing on systematic screening and management. Pulmonary hypertension is defined as the mean pulmonary arterial pressure more than 25 mm mercury at rest as assessed by right heart cath. And we know that pulmonary hypertension is a deadly disease. This is data from the REVEAL registry in the United States showing that patients with pulmonary arterial hypertension, the mortality is more than 50% at 5 years. The prognosis is as bad as patients with cancer. And also, we know that patients with pulmonary hypertension, their clinical functional class is a major determinant of the outcome. The better functional class, the better outcome of this patient. This highlighting that if we were possible to diagnose this patient early, we may be able to improve their clinical outcome and prognosis in long term. As such, this is being recommended in the European guideline in terms of management of pulmonary hypertension. They suggested that patients with connective tissue disease, particularly systemic sclerosis, would require annual echocardiographic assessment in order to screen for asymptomatic pulmonary hypertension and then followed with subsequent management in the hope that we can improve their clinical outcome. So why we want screening? Screening was a principle of disease screening. Screening is a test of apparently healthy population to identify previously undiagnosed disease or for patients at risk of certain condition. So that is one we want to pick up the disease earlier. But there's some important prerequisite to make screening effective. First, the condition have to be of high preference. The condition have to have a serious outcome, and more importantly, early detection and is easy and available. And early detection can leading to a intervention that can improve the patient outcome. So these are some of the principles for screening. And in pulmonary hypertension, we know that, in fact, this is from the US registry, they found that, yes, patients with systemic sclerosis have a very high prevalence of pulmonary hypertension, so that screening may help us to pick up more of this patient in the early phase. And how screening being performed? One of the major tools to diagnose or to screen for pulmonary hypertension is using echocardiogram. One of the major parameters that is commonly used in clinical practice is to estimate the right ventricular systolic pressure using the pulmonary the tricuspid regurgitation flow that we can detect on echocardiogram, and by the equation we can easily estimate the peak pulmonary pressure. And this is some of the data being shown before. They try to compare the echocardiographic defined pulmonary hypertension, which because this is talking about the peak pressure, so typically take as 35 mm mercury, and compare with the right heart cath measure the mean pulmonary arterial pressure and see whether there's any major correlation there. And in fact, they found that yes, overall, we see a correlation between the echo-divided peak pulmonary pressure compared with the mean pulmonary pressure as we obtain by the right heart cath. And the correlation is fairly positive. However, by using this method, we do have patients that with pulmonary hypertension we fail to detect because of false negativity. At the same time, some of the patients, they do not have pulmonary hypertension, may label pulmonary hypertension because of this false positivity of the test. And such, we know that in fact not just only the pressure, in fact other echocardiographic parameter, for example the right ventricular size and the pulmonary artery size, and also the inferior vena cava and right atrial size, and also other parameter may help us to define or to have a better determinant of pulmonary hypertension likelihood. And this is from the European guideline. They use, first of all, the peak tricuspid regurgitated velocity together with the presence or absence of pulmonary arterial hypertension sign as the structural changes, for example, the RA, right ventricle, and also the inferior vena cava size, to try to stratify this patient into low probability and high probability of having pulmonary hypertension. And with that, we can decide what to do next. More commonly will be a right heart cath. And here you can see that by having the echocardiographic probability together with the clinical parameter of this patient, then you can decide whether this patient need to proceed for a right heart catheterization. And using this data in the West, they have defined a detect calculator for pulmonary hypertension, so that you need to punch in all this information, both clinical, biochemical, and also the echocardiographic parameter, and they can give you a prediction of pulmonary hypertension likelihood. But this is in the West. How about in the Asian Pacific region? In fact, we don't have good data to support all these screening method or screening tests. And now I'm going to share with you some of our experience in Hong Kong and how we handle this problem. This is the hospital I work in, Queen Mary Hospital in Hong Kong, serving a population of 530,000 patients. And we do have a rheumatology center here so that we can assess patients with connective tissue disease. And this is the data from our cardiology unit for patients undergoing right heart cath. In fact, you can see that connective tissue disease and congenital heart disease are the main bulk of patients that we could diagnose pulmonary hypertension. And other will be patients with cirrhosis, because we are also a liver transplant center. And a few years back, we have formed a group called the HKU Hong Kong Macau Pulmonary Hypertension Study Group in order to facilitate research and study in our region. And also develop an app that can help us to estimate the pulmonary arterial hypertension risk for our patient. And with this group, we started to work further. In this app, you can punch in different data, and so it can help us to estimate the patient survival rate, and in order to dictate our management plan. And our group also started a screening for pulmonary hypertension study in patients with systemic sclerosis. And for all these patients with systemic sclerosis in Hong Kong and Macau and in the participating hospital, we will have their baseline demographic, and we perform BNP, echocardiography, and 6-minute walk, and to determine this patient whether they are high probability or low probability, and then to try to follow what we see in the Western world, and to see whether we have similar results. What we find is that all of the patients with systemic sclerosis, in fact, majority of them, something like 79%, they have low probability of pulmonary hypertension, but in fact, 21% of them, in fact, was classified as intermediate to high probability of pulmonary hypertension, which is quite high and also comparable with the data in the Western world. Something like 1/4 of patients with systemic sclerosis might have pulmonary hypertension. And then we try to see whether the right ventricular systolic pressure can correlate with the BNP, because we want to find simple method in order to pick up this patient early. And if you see here, for patients with low probability, as classified by the echocardiography, you can see that their BNP used to be low. At the same time, the RVSP are low. And for patients with intermediate probability, they have a higher RVSP, and the BNP is in the middle. And for a few patients with high probability, they have a high BNP and also high RVSP. However, the specificity is very good, 91%, but the sensitivity is not very good, only 68%, suggesting that this method may not be very useful, very sensitive to pick up all patients with pulmonary hypertension. And from our study, we have go all the way for patients with intermediate and high risk, and we go for right heart cath. In fact, only 50% of these patients will eventually find to have pulmonary hypertension, and the mean pulmonary vascular resistance is 5.6 Wood, and majority of them, 95%, are considered class 1, and CTAP, group 4, is only constitute 5%. However, in Asia Pacific region, systemic sclerosis is not the major connective disease that we have. In fact, we have more patients with systemic lupus erythematosus (SLE) rather than systemic sclerosis. And this is from Dr. Mok in Hong Kong. showing that in fact in Hong Kong, SLE constitute something like 28% of all connective tissue disease, and systemic sclerosis only account for 2%. So that for just screening patients with systemic sclerosis may not be useful. However, in the world, systemic sclerosis is of much lower prevalence in the Caucasian population, whereas in the Asia Pacific region and also Eastern Europe, systemic sclerosis is more common. And this is the cause of death in Hong Kong in patients with systemic sclerosis and also patients with SLE. And you can see that many of them, they have cardiovascular disease. They die of cardiovascular causes, which is very common. In fact, if we go back and look into the clinical data, the prevalence of pulmonary hypertension in patients with SLE, in fact, there is only very limited data being published. And majority of them, you can see that the prevalence is not low, but it's vary a lot. For example, it can vary from only 0.5% all the way to up to close to 20% in different series. So that is highlighting that we do need more information to inform our clinical management plan, whether we need to do systematic screening for patients with SLE in Asia Pacific region. And this is one of the studies that we have initiated. This is called the SOFI study. It's a screening for pulmonary hypertension in systemic lupus erythematosus patient. In fact, many of my colleagues in Hong Kong, Macau, and also mainland China has been participating in this study. What we want to do is to do a cross-sectional multi-center screening study to pick up patients with SLE, pick up patients with pulmonary hypertension in patients with SLE. The estimated sample size is around 800, and we hope the target sample could be more than 2,000 in order to increase the representative of the condition. And this is the workflow that we have for patients with SLE. We will do all these baseline screening tests, including ECG, BNP, 6-minute walking distance, and echo. And for those patients considered high and intermediate probability, we will go ahead for right heart catheterization. And this is the workflow for the SOFI study. So what we have done, altogether in Hong Kong and Macau, we have screened out altogether more than 1,000 patients not previously known to have pulmonary hypertension. And of this patient, something like 200 is from the were diagnosed to have 187 patients was considered an intermediate to high probability of pulmonary hypertension, and 82% they consider have a low probability of pulmonary hypertension. And if we compare patients with low, intermediate, and high probability, you can see that age is an important determinant of the pulmonary hypertension, and then the resting blood pressure. And at the same time, you may see that, in fact, the presence of Raynaud phenomenon, or the patient with mixed connective tissue disease, and patient with telangiectasia that you can detect on the patient face, is also some important clues that this patient may have, in fact, having pulmonary hypertension. And for the rheumatology part, we found that the presence of anti-RNP antibody is also a major determinant or the marker to suggest this patient may have underlying undiagnosed pulmonary hypertension. And obviously, patients with high pulmonary hypertension with high probability, they have a higher BNP level. And with that, we know that we can screen out patients with in SLE to have to diagnose pulmonary hypertension much earlier on. And that's not the only thing that we need to do. After we screen them out and diagnosing them, we want to manage them and to make sure that they are of low risk or they can start medication that can help. And this is what being recommended in the European guidelines, suggesting that how we assess this patient. They have this what we call the traffic light risk assessment tools, including red, yellow, and green. And we want to put our patient into the green zone. This including clinical parameter like clinical sign, symptom, the functional class, 6-minute walking distance. we can have some biomarker like NT-proBNP, and also imaging, for example, echo and also hemodynamic things. However, in Hong Kong and maybe in Macau as well, other than clinical assessment, biomarker is not easy, like NT-proBNP is not routinely available, and echocardiogram and right heart cath is not commonly performed in patients just for reassessment. And how do we do? And this is a survey from our study group. We're asking our colleagues how you assess the patient when patient with pulmonary hypertension come back to your office, and when will you consider escalating your treatment. And most of the time we rely heavily on symptom, functional class, and if possible 6-minute walking distance. And the major determinant for us to consider escalating drugs, for example, the endothelin receptor antagonist, mainly when the patient develops worsening symptom or with a worsening hemodynamic parameter. And in fact, this may be too late. And so in our hospital, we start to have a systematic periodic reassessment for patients with pulmonary hypertension in order to escalate the drug treatment much earlier on. This is the flow chart that we have. At baseline, patient with pulmonary hypertension at the time that they're being diagnosed, we will have the NT-proBNP, 6-minute walking distance, echo, and also right heart cath to get all these invasive and non-invasive parameters. And then we will start, if we confirm the diagnosis, we will start this patient on PDE5 inhibitor, particularly sildenafil. And then 6 months, we will repeat everything: blood test, walking distance, echo, and also right heart cath. And if the data is not good, we will escalate the drugs, including the use of endothelin and receptor antagonists. And then at 12 months, we will repeat everything the same. And if this is still not good, we may consider to escalate into prostaglandin analog, for example, cilostazepam. And then at 18 months, we will repeat everything again. And we hope that by doing that, we can have assess this patient periodically, can pick up whether they respond to drug treatment or not, and then we can escalate the treatment that we want. This is what we have done over the past few years. We look back to see compare our patient under newly diagnosed with pulmonary hypertension, and then compare with the those patients that we managed in the old way in year 2010 to 2017. And this is the data that we have. Compare patients that in the past that we use conventional method, and now we use systematic periodic assessment, and to see whether we can have a better outcome of this patient. First of all, we look into with systematic reassessment whether we are more likely to use drugs that is useful for this patient. In fact, you can see that for patients under systematic reassessment, the chance that the patient being put on sildenafil is much higher than patients undergone conventional management at the end of 1 year. And second, the use of ERA, endothelin receptor antagonist, is a very specific pulmonary hypertension targeted therapy. It's also increased among patients with systemic reassessment. As you can see in this chart, at the baseline, we may not start the drug ERA right up front, but after the second right heart cath at 6 months, you can see that there is an escalation of the use of these drugs, suggesting that the right heart cath and also the periodic assessment at 6 months does provide important clinical information and trigger for clinicians to initiate new therapy. And if we look into a combination therapy, at 1 year, how likely this patient receiving sildenafil and ERA, which is considered as one of the optimal treatment for patients with pulmonary hypertension. In fact, you can see that systematic reassessment gives a higher proportion of patients receiving this treatment. How outcome? So this is the clinical outcome of patients with that under our systemic reassessment. You can see that compared with the conventional assessment, we have less primary endpoint, including death, hospitalization for worsening pulmonary arterial hypertension, and also worsening of the WHO functional class. And for those patients that we have systematic reassessment, and we can have the invasive parameter to reflect how likely or how we change their outcome. And in fact, we can see that as 12 months compared to baseline, the drop in mean pulmonary arterial pressure is significant, from 40 to 50 down to around 30. The pulmonary vascular resistance also drops significantly from 9 all the way down to 4, which is a very important feature of showing that this patient is responding to the treatment. And this is the cardiac output of this patient is increasing. It is, however, the pulmonary capillary blood pressure remains unchanged, which is very typical for patients with pulmonary hypertension treated with the drugs. And this is one example of the patient that we have. At baseline, you can see that this young lady, she have a high anti-proBNP level and a very short 6-minute walking distance of only 400 meters. This is a lady of 40 years old, and you can see how functional impairment she have. And then we start her on sildenafil after the diagnosis, and at the 6-month follow-up, she claimed that she improved a lot and feel that is feeling much better. But in fact, if we do a more objective assessment, you can see that the anti-proBNP in fact is not reducing, in fact is increasing, and the 6-minute walking distance is hardly increased any. And so, with the right heart cath, we find that in fact the mean pulmonary pressure remains very high. The pulmonary vascular resistance also very high. There's no change in the cardiac output at all. And then we start, because of this number, despite she claimed the symptom is improving, we start her on macitentan, the ERA drugs that can also reduce pulmonary pressure. And you can see that her pulmonary vascular resistance drops significantly, and the cardiac output increase, despite the mean pressure does not change. It's also a very important message here that because of the mean pressure doesn't change, and you can see that by doing echo for reassessment may not be very accurate, because echo may only pick up the pressure, may not be able to help us to pick up the pulmonary vascular resistance. And at 18 and 1 year, we repeat the 6-minute walking distance and also anti-proBNP. You can see that this walking distance has increased more than 25%, and also there's a significant drop in the anti-proBNP. And then we further escalate her using cilostazepam, a drug that is called the prostaglandin receptor analog, and then we can further reduce the anti-proBNP, increase the 6-minute walking distance, and we see the drop in the mean pulmonary pressure, as well, more importantly, the pulmonary vascular resistance. And we think that this is a very important finding. However, we may not want to have this patient undergoing right heart cath every 6 months, because this is expensive and this is also time consuming. And in recent years, we started to work on wearable technology, which can tell us a lot of patient physiological parameters continuously at home. And this is one of the systems that we have been using. It can measure the heart rate, oxygenation, respiratory rate, activity, and also skin perfusion. And we have also already used it in patients with heart failure in Hong Kong. And then we are now exploring the possibility to use this technology in patients with pulmonary hypertension. And by using this technology, we can continuously monitor this patient at home, and the data will send back to our cloud. And clinician can can monitor this patient in their office every day. And we try to develop a machine learning defined algorithm in order to pick up possible pattern that can indicate clinical deterioration. As such, we can initiate treatment much earlier on, and without using invasive method. And this is some of the early phase data dashboard that you can see for different individuals. So I'd like to conclude my talk as such. I think connective tissue disease is an important cause of pulmonary hypertension, and SLE is more common in Asian than in Caucasian. And we found that the prevalence of pulmonary hypertension in SLE Asian patient is around 10 to 20%. And because of that, systematic screening allows early detection and diagnosis of PH and may improve this clinical patient outcome. And we work on systematic clinical pathway that help to escalate treatment for this patient and hopefully can translate into clinical outcome. We are now in the phase to develop remote wearable technology to monitor this patient, and hopefully we can have better prognostic indicator in order to guide our clinical decision. And I'd like to thank this opportunity to talk with you, and I'm sure that you may have some question for me, and here is my email address. In fact, you may have some question, and we can discuss over email. And thank you very much.